Hello students, my name is Moon and this is He200, also known as the EMT class at Queensborough Community College. I am making this recording of the lecture due today or scheduled for today because I am unable to be there in person. Why not? Let me just say that mistakes were made and further explanation will be forwarded to you. So let's get on the lecture today. So trauma to the head, neck, and spine. So it's not just a simple matter of C-spine, because there are other things you can do in the primary and secondary after you have ensured that the patient's C-spine is protected. And that's what today's lecture is all about. So when we worry about the head, neck, and spine, yes, we're worried about cardiovascular issues, we're worried about musculoskeletal issues, but it's really the nervous system. After all, the spinal cord goes right through the cervical spine, and that's why we're so obsessed about protecting it. The problem is that other problems, if the first EMTs on scene didn't take care of it, then other EMTs and paramedics who show up later and the ER when the patient finally arrives, they'll be able to do something as long as you are covering the ABCs and treating for shock. With a C-spine injury, the problem now is that if there is a cervical spine bone fracture and it does sever the spinal cord, that's it. It's not growing back. It's not being repaired, at least at the state of medical technology and knowledge it is today. Maybe someday they'll be able to figure out how to make nerves grow again, but so far not. So you who are the first EMT on scene, if you don't protect the C-spine, and then during extrication, during transfer to the stretcher, there is a C-spine damage, that's it. Nobody else who shows up later, not the paramedics, not the emergency room, not the operating room, they can't fix it. So that's why we are so obsessed about it. Okay, let's talk a little bit about the nervous system. Review of the nervous system. There is central and peripheral. Nice picture here. Central is the head, the brain and the spinal cord. That's central. And then the peripheral is anything else, everything on the side. Within the peripheral nervous system, there are vertebral nerves, which means nerves that come right out of the spinal cord heading towards the rest of the body. And then there is the regular, all the other nerves that are taking care of it, taking care of the rest of the body. Okay, among them, the nerves there that expand out from the brain, at least, I mean, once it leaves the brain, then the nerves are either motor or sensory. Motor are all nerves that go from the brain to the rest of the body. Sensory are all the nerves that go from the rest of the body back to the brain. So that information can go to the brain figures out what to do next, and sends commands to the rest of the body to do whatever it is they need to do. Okay, so up to the head, starting at the head, the cranium is the part of the skull that's not the face, and the face means these. So mandible is the upper half, I'm sorry, the mandible is the jaw, the part that flaps up and down when you're talking. Maxilla is the cheekbones, the upper half of the mouth. Nasal is nose. Zygoma or malar is the cheekbones, and orbits are around the eyes. How does the spinal cord leave the skull, the cranium? And it's through the foramen magnum, literally hole big. So the biggest hole in the brain is the foramen magnum. I sneak peek ahead, I see that there isn't a very good picture of the foramen magnum, so let's go have a look at it. Here and then here. So whoever made these drawings, please don't sue me. This is for educational purposes. This is the bottom of the skull looking up, and here it is. This is where the spinal cord leaves the brain, heading down to the rest of the body. Okay, and let's have a look at the face bones here, and let's see. Too much information. This is better. In fact, this is a good one. All the words here you need to know. Maybe not the lacrimal and the sphenoid, but you definitely need to know the frontal bone, the parietal, the temporal, the occipital, which is the back of the head, the mandible, and the maxilla. In the around the spinal cord, it would be nice to have a shock absorber, a layer of fluid that helps avoid the jarring impacts that get transmitted to the body throughout the day, you know, running, jogging, falling. And so there is the cerebrospinal fluid that the entire central nervous system kind of sits in. And central nervous system, remember, means the brain and the spinal cord. The cerebrospinal fluid, otherwise known as CSF, also contains, is also the way for vital nutrients to pass from the bloodstream back into the central nervous system, and it's also the way that waste products are transmitted from the brain out to the cerebral circulation. Well, wait, why don't they have their own capillaries, arteries, and nerves and veins to do that? Why do you need cerebrospinal fluid? Because the circulation doesn't reach the brain. It looks like it. If you look at an anatomy picture, I won't do it now, but if you look at an anatomy picture of brain matter, especially, you'll see blood vessels going in and out, and so it looks like they are well perfused, but actually there is a tiny microscopic gap between blood vessels and the brain matter itself. So the cerebrospinal fluid's job is to relay the nutrients and the wastes in and out as needed. Why did whoever designed this, or whatever designed this, why did they set it up like this? Well, infection. Infection is can surge throughout the body, and if there's an infection in any other part of the body, that's bad, but there's a little bit of time. There is some time to fight it off. But if an infection jumps out of the circulation into the brain, and then the seconds are ticking out. So there needs to be, it was great to have this protective layer so that infection doesn't highway through into the central nervous system. Oh, here's a very nice one. Oh, so the sphenoid, this is from your textbook. The sphenoid bone is in your textbook, so yes, you need to know it. The nasal bone is your nose, not the cartilage. The cartilage sticks out, and that's the rubbery, flexible thing that you can feel at the tip of your nose. But that's cartilage. The bone, you can tell it's bone when it's rigid and does not move. So you can feel it on the bridge of your nose. Lacrimal is Latin for tears. I think the Spanish word for tears is also lagrima, I think. So that is the bone around the tear ducts. Orbit surrounds the eyes, the eye socket. Vomer is the lower half of the nose. Maxilla is the top of the mouth. Zygoma are your cheekbones. You can feel it on yourself. Temporomandibular, well, that's a multisyllabic, many-letter word, but let's break it down. Temporo, so the temporal bone. Mandible, so the jaw, and so the temporomandibular joint is that hinge that you can feel as you waggle your mouth up and down. Inside the cranium, which is the bowl of that contains the brain, are the lobes. But you remember there was a frontal bone and a parietal bone and occipital bone. So sure enough, there are lobes of the brain. And that's about as much as you need to know. You don't need to get into any more detail than that. If you must know, there are some things like the frontal bone is the bone, I'm sorry, the frontal lobe is the part of the brain that is our advanced human brain functions like socializing, language. Well, socializing is a little deeper now. Language is so far our sophisticated language seems to be unique to humans. Our advanced abstract thinking is all the way in the front. Our ability to create and manipulate advanced sophisticated tools seems to be in the front. The occipital lobe, all the way in the back, ironically, is for your image processing. So your eyes take signals and then sends it all the way to the back, to the occipital lobe for image processing. Parietal lobe is all about muscle control, muscle commands, but muscle coordination is in the cerebellum, this cauliflower-looking thing there. You already heard about the brainstem, and that is your automatic autopilot functions like respiratory control, heart rate control, other base foundation control structures so that your body can maintain homeostasis. The stuff in the middle, that's your lizard brain. Those are like memory control. There is emotion control is down here. So, and that's been with our ancestors from all the way in the beginning. So cerebrum, let me go back one. Cerebrum is the big arch. Cerebrum is everything that's not cerebellum or brainstem. So that's everything else. That's cerebrum. That's where all that thinking happens, all that logical processing happens. There are two halves of the brain. And they're called hemispheres. Brain. Here, so we saw a side-on view, but here is a front-on, top-down view. Here is a front-on view, and there are two halves of the brain, and you may have heard theories about how the one half of the brain is like one side of the brain is focused on some things, and the other side is focused on other things. Neurology is really very interesting. It was one of my most favorite subjects. The cerebellum, that cauliflower-looking thing, is about balance and body movements. People who have problems there have trouble being able to stand up straight and coordinate muscular things. Brainstem is your autopilot, like I said. The spinal cord does no thinking, as far as I know. The spinal cord does no thinking. It's just a relay. It's just a mass of wires that's sending signals up and down the body, from the brain out to the body, and from the body back to the brain. Covered in CSF, the fluid, but then around the CSF are membranes. But that's not a surprise to you. Everything is covered in membranes in anatomy. And just like the lung membranes are called pleura, and the heart membranes are called pericardium, then the membranes around the head are called meninges. If that sounds familiar, you may have heard the word meningitis. Remember, itis means inflammation of, so meningitis is inflammation of the meninges. Inflammation can come from all kinds of sources, but when you're told somebody has meningitis, then the suggestion is that it's some kind of infectious disease going on. So the meningitis, and there are 3 layers. In anatomy, lots of things come in threes, and unfortunately you need to know this. You may wonder, why do I have to know this? I'm not going to be a neurosurgeon. I'm just going to wrap him and go. Yeah, but especially the top one, which is the dura mater, does show up on state written exams, and we'll get into that why. But anyway, there's the 3: the dura, the arachnoid, and the pia mater. Arachnoid matter is the full name. So dura means tough, durable, tough. So that's a way to know it. When anatomists, dissection doctors looked at people inside people's skulls a long time ago, they noticed that just underneath the bone of the skull, just underneath the cranium bone, there is this tough fabric that was separating the rest of the brain from the skull. And they said, oh, it's pretty durable, so they called it dura mater. The next layer under the dura is called arachnoid, and if that sounds like spiders to you, it's because if you look at the arachnoid space, the arachnoid matter, under the microscope, it's kind of hard to tell with the eye, but under the microscope, the people said, the people who discovered it said, hey, this looks like spider webs. So that's arachnoid matter. The pia matter is right up against the brain. There's nothing between the pia matter and the brain. You can't like peel it away or separate it. I'm not sure what pia stands for means. In fact, why don't we look that up together here? So let's go to your favorite search engine, pia matter, and then etymology, which is the history of the word, and it came from, well, it's not telling me what it originally came from. Why is it called pia matter? Tender. Oh, I guess it's Arabic for tender. Does anybody know Arabic? Can somebody email me and confirm or refute whether tender means tender? Translate Arabic. Oh, that was a fail. Tender, translate Latin. Oh well. It was an interesting rabbit hole that kind of went to a dead end. But anyway, it sounds like, anyway, the PIA is not something an EMT will run into. It's the one that's right up against the brain. Arachnoid matter you may run into when you read a radiologist's interpretation of a stroke, because sometimes bleeding happens under the arachnoid matter. But as an EMT, you do run into diseases or medical issues that are above and below the dura mater, because that's where the word epidural comes from, and subdural. You've heard of the word epidural. If you or somebody you know has been pregnant, then they are familiar with the term epidural for anesthesia. Okay, how the nerves work. So remember that sensory nerves transmit signals from the body to the brain. So your senses, and you know there are, in the general public, they know about the 5 senses, but there's many more. The 5 senses is just the general myth that there are only 5. There are many more. But anyway, your outer body, your body senses the environment. This guy is feeling the texture of a baseball, and the sensory nerves transmit that sensation, the temperature, the pressure, texture, and sends it to the sensory nerve up to the spinal cord, where it hops over to a spinal cord nerve, again a sensory nerve, that goes up to the brain, the part of the brain in charge of receiving information. The information is then processed. The brain says, yes, I have a baseball in my hand. And then let's say the brain decides to throw it. Then the appropriate signals are sent to the parts of the brain in charge of motor, muscle control, and the individual nerves for all the different muscles are sent down, probably making a bypass through the cerebellum so that they can stay coordinated, comes down the spinal cord, takes an exit ramp out of the spinal cord, and then into the motor nerve to the fingers and the hand and the shoulder, to get ready to throw that baseball. This is why when we check for circulation, motor, sensory, we have to do both motor check, sensory check. So the motor check is wiggle your fingers or wiggle your toes, and then the sensory check is which toe am I squeezing, which finger am I squeezing. I don't think you need to know there are 31 pairs of spinal nerves corresponding to each branch that sticks out from the spine. Just know that there's sensory and motor. You should be familiar that there are 12 pairs of cranial nerves. And what does that mean? What do they mean by cranial nerves? Let me do a quick scan of the slideshow, and no, cranial nerves are not revisited again. So I'll just tell you that unlike regular nerves that have to take an exit ramp out of the spinal cord information superhighway and then enter the body, cranial nerves go directly from directly from the brain out to the head. And that's why cranial nerves only involve the face and head and a little bit of the throat, but that's about it, right? Because anything else is just too far away. They need to take the highway. So cranial nerves are like the local roads that go straight out of the central headquarters. For those of you moving on to nursing, the nursing program, the PA school, and of course paramedic school, then you have to memorize the 12 cranial nerves, but not today. Okay, remember 712-554, the bones of the spine? So now be aware that out of the gap between the one above, the vertebrae above and the vertebrae below, there is a spinal nerve. There is a peripheral nerve that sticks out and then heads out to the rest of the body around there. Which means that depending on which parts of the body they can feel and which parts of the body they can move, there is a way to zero in on exactly where on the spine the injury is, or at least what level of the spine. You as the EMT who did a appropriate physical exam on your patient before he arrived to the emergency room, you could help them cut to the chase. You can say patient has a penetrating wound to T7. So the attending physician realizes you meant level 7 of the thoracic spine, and now the attending ER physician can now tell the neurology consult, you better look around there, look around T7, because the EMTs who brought this patient in said there was a penetrating wound. And sure enough, the patient is unable to feel anything from T7 down, but everything from T6 and up is fine. Okay. Unable to move is paralysis. Unable to feel is paresis. Let me double check that. Paresis. Skip the AI. Always skip the AI. Oh, paresis is weakness. Paralysis is just not moving at all. Paresis. Always double check your source. Weakness. Oh, sorry, paresthesia. Paresthesia. Paresthesia is unable to feel. So, this thing, clevelandclinic.org says paresthesia is tingling, numbness, pins and needles. Well, that's the thing, right? Because what is the nerve supposed to be doing? It's sending a signal. There is a electrical signal being conducted through this wire, and it's supposed to be coordinated so that just like a signal going through a television cable will show a beautiful image, beautiful, entertaining, compelling image. But if that wire is on, the wire is on, but it is not coordinated, then it's going to send static. The random on and off of each wire results in contributing to this image of static. No recognizable pattern on that signal. And sure enough, when you feel pins and needles, you're feeling this random on and off of the nerve, as the nerve doesn't have any guidance or control of what signal it is sending. So pins and needles is a feeling of static, and that's what happens when you bang your funny bone on the table and your hand feels like pins and needles for a while. So anyway, that was paresthesia. Paresis is weakness. Paralysis is just no function at all. In between the vertebrae, which are the bones of the spine, there are shock-absorbing cushions called intervertebral discs. So again, let's break it up. Inter means in between. In between the vertebrae, there are these cushions. If you've ever heard of somebody who suffered from a slipped disc, that's what's going on. This cushion slipped out. It's very painful. It's definitely a 911 call if it happened acutely and they need to talk to a surgeon. This could happen to you, by the way, if you lift wrong. So BSI in safety, always lift with proper technique. If the situation looks suspicious, it looks unstable, you don't honestly believe that you can lift whatever it is you're supposed to be lifting but safely, then call for help, call for additional resources. What this diagram is a picture of a reflex. So remember how the previous pathway worked: sensation, sensory, spinal cord, up to the brain. The brain thinks about it, says, that was hot, maybe I should stop touching it. Sends motor down the spinal cord, out the motor nerve to the arm that pulls the hand away. That takes too long. By the time your brain is finished thinking about it and the signal to move comes out, there's already been significant burning to the finger or something like that. So a reflex goes up the sensory, and then part of the signal splits out, goes up the spinal cord to the brain, so the brain can go, ow, that's hot. But then part of that signal, the other part of that signal, jumps right on the outbound motor nerve arc and goes straight out to the muscle, and then says, get your hand out of there. So what happens is, when you've touched something hot and you didn't realize it was hot, you pull your hand away, and then like a split second after you pulled your hand away, your brain says, ow, that was hot. That is a survival adaptation. You are grateful that it happened. You didn't want to wait until your mind thought about it. It's just do it, and then worry about how bad it felt later. That is a reflex. Okay, quick recap of the anatomy, chapter 6. So I did say that the peripheral nervous system is motor and sensory. That's one way to divide the world. But there's another way to divide the world, which is involuntary and voluntary. Voluntary nerves, and this is all motor. Motor is divided into involuntary and voluntary. So voluntary go to the skeletal muscular muscles. Remember the difference between skeletal and smooth. And primarily skeletal. Involuntary primarily goes to smooth muscle. Some involuntary nerves go to skeletal as well, but let's not get lost in the details here. So for now, just remember that voluntary motor nerves go to skeletal muscle, and involuntary motor nerves go to smooth muscle. Okay. There's the voluntary, involuntary. Involuntary is now divided yet again into sympathetic and parasympathetic. Another word for involuntary is autonomic. Again, auto means, this one means automatic. So you don't think about it, it just happens. It just does it without your conscious input. So it divides yet again to sympathetic and parasympathetic. And this one I've mentioned before long ago. Sympathetic is your stress response, ready to fight or flight, fight the attacker or run away, whatever it takes to survive. But in order to get your body ready for combat or for heavy vigorous exercise, it has to shut other systems down. It's like you're the captain of a ship. Your ship is about to go under attack. So you order battle stations and red alert battle stations and then divert all power to engines. Well, where's this power coming from that you're diverting away from? Well, like the bathroom, the library, the entertainment center, the kitchen, building maintenance. All of those things are not necessary to survive the battle right now, so those things are shut down. But if you are under stress for too long and you sacrifice all those other things, then eventually the fact that you're not doing all those other things are going to catch up to you, and that's chronic stress. What are these other things and how are those triggered? The rest and digest. So parasympathetic. Digestion. Wait, don't you need food energy in order to fight in flight? So why did you shut down the cafeteria? Why did you shut down the digestive system? It takes hours. It takes hours for the energy from the food you eat to reach your muscles to be any good. But in long ago, when all of this was like evolving, survival was a matter of seconds or at most minutes. So there's no time to spend energy digesting food when you needed that energy for battle. So the digestive system was shut down. What else was shut down? Your immune system. Wait, don't you need your immune system to fight off infection in case the tiger bites you or your opponent scratches you? Infections mess you up hours to days later. Again, if survival is a matter of seconds or minutes right now, then you don't have time to worry about infection tomorrow, and you don't have the energy to spend on immune defense for things that'll make a difference tomorrow. You need that energy to help you fight or run away right now. So the immune system is shut down. Lots of other things are shut down. Investing, repair, growing, thinking ahead into the future consequences of your actions. During the sympathetic nervous system, your brain is focused on the here and now, zeroed in on what's immediately in front of you, what's immediately at hand. Your brain is not spending time thinking of future consequences of your current actions. That is what the parasympathetic is all about. And this is why people say and do things at peak emotional events that they later regret. Okay, enough about anatomy review. Let's go into what you do as an EMT. You see this. What do you do? Well, BSI, see gloves, scene safety, whatever happened to this guy, make sure it doesn't happen to you. A mechanism of injury looks like some kind of trauma, maybe a fall, maybe a stabbing. Number of patients, 1. Consider additional resources, maybe medics, police, if this was an assault, etc. And consider C-spine, absolutely. Whatever caused this could have injured the neck, and unless you cannot be sure that the the neck and the spine are not injured, put a C-collar. Absolutely have your partner hold manual stabilization, and then by the time you get to the secondary, somebody should have put on a C-color. Okay, mental status for sure, general impression, mental status, chief complaint, whatever the patient is saying. Airway, breathing, circulation for sure. Doesn't seem to be a lot of bleeding going on though, but maybe he's already in the emergency department. But airway, breathing, circulation, make sure it's all good. This is definitely a load and go. Even though this may not look like an immediate life threat, how is that possible? How can something this deep and big not be a life threat? Well, is it affecting the airway? Is it affecting his breathing? Is it affecting blood pressure, perfusion of the rest of the body? But is it causing him to be altered mental status? What if this guy is holding a full conversation and is like, what happened? And he's telling you all about what happened. You know, goddamn son of a bitch stabbed me in the head. You know, he owed me money, and I tried to get my money back, and then he cold cocked, and then he sucker punched me, and then he stabbed me, and I chased him down, but he ran away. So he's having this whole full conversation. He's alert and oriented, person, place, and time. So by those facts, because that's how he taught you to assess primary, you would say this sounds like a stay and play. No ABC issues, no mental status issues, no shock. However, because we're now talking about the skull and the brain, it could become a life threat pretty quickly. So make it a load and go. Then what do? Well, in the secondary, of course, bandage. Of course, 4x4 and bandage. And we'll talk a little bit about how to put appropriately. So this gentleman, is this a male? I shouldn't assume. Did this person get direct or indirect injuries? I don't know. Anything either could have caused it, but direct means the penetrating object actually caused it, while indirect means that the initial impulse, the initial impact sent the head in another direction, and the fact that it did, and then maybe the head made impact with the ground or the wall or something else, and that caused the problem. So that's indirect. Concussion, contusion. You'll see this. You may have heard these two words back and forth, and you may have wondered, do these two mean the same thing? No, they mean slightly different things, and there's a slide to explain the difference. Okay, scalp is the skin along your head, and then skull is the actual bone. Just like the face, and I said this last week, just like the face, the scalp has lots of blood vessels, which can cause bleeding in excess to the seriousness of the injury. So it's possible that you show up on scene and the patient, and it looks like a horror show. There's blood everywhere. But then when you finally get to the injury itself, you see it's just a tiny little cut, because all of that blood is coming out of that dense area of blood vessels. I'm not saying don't take it seriously. Of course, take it seriously, but that could be very much what's going on. And open injury means the skin is broken. Closed injury, head injury, means the skin is intact, and then all you're seeing at most is bruising, contusion. But like I said last week, purple, dark discoloration on the skin, in our life, in our own sheltered, protected life, when we saw bruising, it was a minor injury. Unless you've experienced the opposite, unless you've experienced true serious trauma, then you know different. But for many of us, we lived a casual, sheltered life, and bruising was just a minor injury. But as an EMT, you should now know that bruising could be a sign of a severe bleed internally, and but it's so deep that you can't see it, and the only thing you can see is the hematoma, the bleeding that is just under the surface of the skin. So any injury to the head, head, neck, and spine, but any injury to the head, you should take seriously. Definitely take C-spine, manual stabilization of the head before the in the primary, and then collar by the secondary. Open and closed, I said that already. Okay, so the difference between concussion and contusion. Did I make it? Here it is. Concussion and contusion. Concussion causes no actual cellular damage. Contusion actually does cellular damage, and when there is cellular damage, it may be permanent. So a concussion is temporary, and that's the guy who is wearing a helmet, appropriate helmet, gets hit in the head, and then gets knocked out, or is knocked dizzy for a little bit, made confused for a short amount of time. But then after like a little bit of time to get his wits together, and then he comes back to, and he's alert and oriented again. It was temporary. That's a concussion. You look under the skin, you take an x-ray, you take a CAT scan, and there's no damage found on imaging. Contusion is same story, but then you take off the helmet and you see there is bruising. You feel around and there is deformity. Maybe there is a broken bone. You take x-ray, CT, there is damage seen on image. So that's the difference, concussion versus contusion here. So this poor fellow received some kind of blunt force to the front, and then may have been knocked dizzy for a bit, and that's a concussion. But then if he has actual brain injury, cellular injury, bruising or worse, then that's a contusion. So I expand. This is a slide that I modified. I expanded it out, the definition of concussion. To get a bonk on the head, it doesn't automatically require that the patient lose consciousness to get a concussion. But anybody who did get bonked on the head, it's in the principle in healthcare is hope for the best but prepare for the worst. Don't just tell him to walk it off. Don't tell him to get back into the game. Have somebody who is experienced and expert, trained, assess the patient, and do all of the the appropriate assessments like mental status check, physical exam, blood vital signs, all of that, and then it's always a good idea for this person to go to the hospital anyway. Contusion, there's no way for an EMT to know the difference between concussion and contusion on scene. This is absolutely a determination made by, assuming that it's a closed injury with no external signs, so no bruising, no bleeding, then and no deformities, then there's no way to know the difference. So that's why we should take him to the hospital. We hope that it was only a contusion, but we hope it was only a concussion, but just in case it's a contusion, they need to go to the hospital. Okay. Laceration is a tear of flesh, whether it's skin or deeper. Hematoma is a collection of blood that spilled out of the blood vessels, out of the capillaries, out of the arteries and veins, and formed a mass of blood accumulating there in that space. Okay, and here's that word, epidural, and here is subdural. So a hematoma that is subdural means it's under the dura. The hematoma that is epidural, that it means it is above the dura. And intracerebral, intra means inside. Inter with an E means in between, but intra means inside. So inside the brain, an actual bleed. So nice drawing of the difference. There is the dura is this blue lined membrane. So a subdural is under the dura, an epidural is above the dura, and a bleeding right in the middle. So I said that the cerebrospinal fluid separates the blood vessels from the brain, but there are blood vessels going in and out of the cranium, but there's still a microscopic separation. But anyway, the blood vessel now burst, and now the blood is spilling out into the cranial space. How do you supposed to know the difference as an EMT on scene? One of these three. Well, it's the story. It's really the story. Of course, you cannot see through the skull. You don't have X-ray vision, so you cannot tell by physical exam. But the way the patient or the bystanders told you how things happen, you can start piecing things through. And this is how it'll be explained to you on the state written exam. The question will tell you the story, and you read the question stem carefully, and now you see, okay, it sounds more like this one, or sounds more like the other one. BSI scene safety, finish the scene size up, go to the primary, verify mental status, protect ABCs. Eventually, by the secondary, you want C-spine on, but at the beginning of the primary, you order your partner to take manual stabilization of the head. Okay. Look for signs of skull fracture, means deformity, the D and DCAT BTLS. So you can sometimes see it. Otherwise, you're going to have to palpate around, but don't press too hard, because you don't want to be pushing skull fragments into the brain, right? Remember raccoon eyes and battle sign? Here they are. This is raccoon eyes. This is battle sign. So definitely look behind the earlobe. And this means blood is pooling from somewhere under the scalp. I added this picture, and this is not from your textbook, but you're going to run into this term when you transport the patient to the hospital. If the facial bone is fractured, it's a Lefort fracture. That's all you need. That's all I want you to remember. Lefort is a rating scale of facial bone fractures, like somebody got punched in the face or something like that. But it's only seen on X-ray, but you can tell that there's been something severely wrong when you see massive swelling in the face area, the same area that the patient took the hit, blunt force hit, or even sharp object hit. Anyway, you should always hope for the best, but fear that there may be a facial fracture. And yes, this space that the artist put in, the space between the maxilla and the rest of the bone, rest of the face, that's actually intended. Like, it could separate that far away from the rest of the skull. Coup contre coup shows up on EMS exams all the time. So absolutely be familiar with it. Coup means head. Coup is French for head. So head, opposite head. So what's happening is this head approaches this immovable object at a high rate of speed. High rate of speed, so we see these things in car accidents all the time. But you can also see it in falls. Anytime that the body is approaching an immovable object at a high rate of speed, what happens is the body itself, the head, comes to a sudden stop, and then the momentum of the brain mass, the brain, how much does a brain weigh? What's the weight of brain? And it is AI, about 3 pounds according to Washington.edu, University of Washington, about 3 pounds or 1.5 kilograms. So 3 pounds was cruising along at the same speed as the body, but now suddenly the body came to a sudden halt from 60 to 0 in 0 seconds, and the 3 pound brain kept going forward, and so now the brain makes impact with the inside of the skull. So that's the coup, that's contusion here. But then what happens? Meanwhile, like it's a slow-mo guy video, a slow motion video, the head bounces off the immovable object and goes backwards and hits something behind them. And now the head again is sent at a high rate of speed. You know what? This drawing is missing something. This drawing is missing this. And don't forget that it had hit here. So let's put this here. And let's draw an arrow to make it clear what's happening. So the head is doing that, and then the head bounced back and now made impact with the immovable object behind it. Ready to send this back into the slide. And yes, I will upload this slideshow, this modified slideshow, in the modified slideshows folder. So the head now bounces off the first object, is sent at a high rate of speed backwards, hits the behind object, and this 3 pound brain, which was accelerated in the reverse direction, now slams up against the inside wall of the skull on this side and causes contusion on that side. So coup, contra coup. How do you know as an EMT that a coup contra coup had happened? Well, look inside the cabin, listen to the story that the bystanders have given you, look at the environment. Is it possible that a coup contra coup happened? And this immovable object in the back doesn't have to be a wall or a fence. It could be the headrest of the car. Anything that'll make the head come to a sudden stop. The front doesn't have to be a wall or a fence. It could be an airbag. Wait, I thought airbags are supposed to prevent that. Yeah, if you are sitting appropriately in the chair, then the airbag will reduce the risk of this happening. But what if you're not sitting appropriately? What if the airbag in your car is not the right kind because you knew a guy who got you a great price on replacement airbags, and now you have the wrong kind of airbag. So whatever head causes the head to come to a sudden stop and then bounce back and come to a sudden stop causes coup contra coup. Okay. Absolutely talk to your patient if they can talk, because you need to assess mental status, and this is very important. Always look for and treat shock. Vomiting, like I've said before, is a sign that the body thinks something is wrong. Vomiting is not specific to any one actual disease. Vomiting and nausea is found in almost all diseases where the patient is decompensating. It's your body's way of trying to do something when it doesn't understand what's going on. Primary and secondary, I believe, so far, the only times you've seen the word primary and secondary is in the patient assessment. The primary checks ABC's mental status, make a transport decision, general impression, of course, level of consciousness, and then secondary is like everything else in patient care. That's true. But in general, the word primary means first or most important. And in general, secondary means second, or happens after the primary, or is second, not as important. In this slide, primary means happens first, secondary means happens next. So a secondary injury is whatever happens to the brain after the first thing happened. So what is an example of a secondary injury? Intracranial pressure. Intra, inside, the skull of the brain, the cranium of the skull, pressure, built up of pressure. Here's a drawing I made, my favorite drawing app, and this is how it goes. There is the carotid artery heading up from the heart to the brain, and then if an artery, one of these arteries, gets cut because of a contusion, then blood pressure is pushing blood into the skull, into the cranium. But the problem is that the cranium is bone. It does not expand like a balloon. It stays the exact same shape. So as more and more blood is pushed into the brain and spills out of that laceration, fills the space, more and more pressure is building up in the cranium. That is intracranial pressure. What caused this laceration? I don't know, some coup contre coup or something, gunshot wound. It could be medical, like uncontrolled high blood pressure finally caused a blood vessel to burst open, an aneurysm. Whatever caused the initial original laceration is the primary injury, and then the spilling out of blood resulting in increasing pressure in the brain is the secondary injury. See how this works? Okay. When the pressure in the brain gets high enough, there is a set of 3 symptoms that seems to occur together, and this is called Cushing's reflex. Watch out, this is not Cushing's syndrome. Cushing's syndrome, I guess they're both discovered by the same Dr. Cushing. Cushing's syndrome is a completely different disease. Do not mention Cushing's syndrome in front of the doctor or the nurse or your PCR when you think it is an intracranial pressure problem, because you're just going to confuse the reader. This is Cushing's reflex or Cushing's triad. Triad means 3, and the 3 are severe bradycardia, which means slow blood rate, severe high blood pressure, and irregular respirations. Okay, and then so here's my simplified explanation of what your official slideshow says. Right. Okay, so here is how this happens. How did this happen? This is how it happened. Somebody suffered an arterial laceration in the brain. The blood is spilling out. With nowhere else to go, it just keeps building up pressure in the brain, causing intracerebral pressure. Eventually, the brain is under so much pressure that it has to find an escape somehow. Just like if there's a hole in the spaceship, air is going to start forcing its way out that hole. Well, what is the biggest hole in the skull, in the cranium? The foramen magnum. The blood pressure buildup is here or somewhere else. Anyway, what's the first thing that's going to head out the foramen magnum? What's the first thing that's going to be squeezed out the foramen magnum under all that pressure? The brain stem. So the brain stem which is bigger than the foramen magnum, is being squeezed out the foramen magnum, and it's creating like a plug, and it's increasing pressure right here the structures right here, such as the carotid artery trying to make its way up here. Okay, so remember the brain stem is in charge of autonomic functions, autopilot controls. One of them is how hard the heart beats. So as the blood flow into the brain is being pinched off by all this pressure, then the blood that is in the brain is becoming more and more deoxygenated as the oxygen in this blood is being used up and no fresh blood, not enough fresh blood is going in. So the brain stem detects the lowering of oxygen and the increase in carbon dioxide, and it's the few motor signals that do make it out the foramen magnum finally make it to the heart and say, we're not getting enough oxygen in the brain. You have to beat harder. You have to pump harder. So that's the hypertension. But now the rest of the body that is not under intercerebral pressure, the rest of the body is feeling this increasing pressure from systolic blood pressure, and they're saying, what are you doing? Where's all this pressure coming from? Why are you beating so hard? And the heart is like, hey, don't complain to me. Go complain to headquarters. I'm just doing my job. Headquarters said, pump harder. I'm pumping harder. Hypertension. And so the rest of the body, the chemoreceptors outside of the skull are saying, we're getting too much pressure here. You got to slow down. If you won't listen to us that you need to pump less hard, then at least slow down so we don't get overwhelmed with malignant hypertension. So the heart slows down, and that's bradycardia. Meanwhile, so what about irregular respirations? The brainstem. What else is the brainstem in charge of? Lots of things. But something else the brainstem is in charge of is respiratory control. And guess what's getting scrambled as it's being smushed down through the foramen magnum? Your brainstem in charge of respiratory control. So the patient starts suffering irregular respirations. By the time the irregular respirations are happening, the EMS is saying herniation. What does herniation mean? Well, we're used to the word hernia to mean something else. We're used to the word hernia meaning the intestines, especially the small intestines, are squeezing through an abdominal opening. But that is a intestinal herniation. Herniation in general in medicine means any body part that's squeezed through a small opening. So since the brainstem is being squeezed through the foramen magnum, we're saying this is brainstem herniation, and EMS just calls it a brain herniation. How well do you think delicate brain structures are going to tolerate being smushed through an opening, jammed through an opening? And if you say not very well, you would be right. This is like early stages of brain damage. This patient is going to die soon. If you still haven't been going lights and sirens, this is a great time to upgrade to lights and sirens and call notification head. Tell them Cushing's triad and suspected or rule out brain herniation. What do they do in the emergency room? Well, they'll move him up to the operating room. But what will they do in the operating room? Well, once the neurosurgeon comes in, they'll probably dig a hole or cut a hole into the skull somewhere else and allow the pressure to come out. They'll probably do an X-ray or CAT scan to identify exactly where the bleed is, where the hematoma is, and through that hole that they cut open with a saw, a circular saw, they may insert a needle and suck out that fluid, bring the pressure back under control. Okay. Irregular respirations. So there are different kinds of irregular respirations, and these are some of them. This is like a short list of the different kinds of irregular respirations. Cheyne-Stokes is definitely worth looking into. You know what, I'm gonna explain it. Okay. Let me make a little shape. And then imagine this graph is your breathing. So you inhale and then exhale, inhale, exhale, inhale, exhale, etc. Right? This is normal breathing. Cheyne-Stokes is the breathing gets here, let me do it this way. Let me show you. This is regular, normal respirations throughout, I don't know, 1, 2, 3, 4, 5, 6, 7, about 30 seconds. This is about 30 seconds of respirations. And now, let's put it in red to show you this is not a good respiration. This is fast, deep and fast, getting worse and worse, and then slower, smaller, shorter, and then deeper, faster, like that. So this is Cheyne-Stokes respiration, and then slower, shorter, like that. So it creates this ribbon like a graph. That's Cheyne-Stokes. So deep, fast breathing, and then periods of shallow, slow breathing, and then periods of deep, fast breathing. Why this happens is a little beyond the scope of this class. Ataxic respiration is just flat out irregular, irregularly irregular. It's also known as biots, although it's not exactly the same, kind of like biots respiration. They're both irregular breathing, just slightly different. But if you see one of the both, that means it's irregular. Decorticate and decerebrate is the part of the Glasgow Coma Scale. So let me check if I uploaded Glasgow Coma Scale for you. There is so this is your lecture Brightspace. Let's go to your handouts Brightspace, and let's look at assessment. No, it's not here. But you know what? Now is a great time to show you. So let me go to my handouts folder. Let me add let me add this one. GCSEC. Okay, here's an explanation of the Glasgow Coma Scale, which we will look at in detail another time. But to give you guys a break, let me just show you decorticate and decerebrate. When you see a person in a coma, looks like they are in a coma, and this is motor 3 and 2. So this is like just before it's completely gone. This is motor 3 and motor 2, decorticate and decerebrate. So to oversimplify, the too long didn't read version is that when they turn their hands in and they're in a coma, this is decorticate, and when they turn their hands out and they're in a coma, this is decerebrate. And why look at my stick figures, decorticate versus decerebrate. And here are some better drawings of person in decorticate and decerebrate. So what's the difference? They're both bad. They're both means that the brain is severely damaged. But if you had to choose, then decorticate is in a slightly better state, and decerebrate is now out. I mean, this guy is pretty far gone just before he goes into complete zero function coma, like no muscle tone at all left. That's the difference, decorticate, decerebrate. This is why this is motor 3 and this is motor 2. There, that is a quick and dirty introduction to decorticate versus decerebrate. So intracranial is hemorrhage, is bleeding inside the skull, causing intracerebral pressure. What can cause it? Well, it can cause bleeding in or around the dura mater. It can cause bleeding of a vessel going in and through the brain itself. Okay, so epidural, above the dura. So that means between the skull and the dura. Not always, but the statistics are that this tends to be arterial. And what's so special about arterial? Arterial is under pressure, under pulse systolic pressure, which means that these bleeds tend to happen rapidly. Intracerebral pressure tends to accumulate rapidly, and you have it progresses through the symptoms in a matter of hours, minutes to hours. You get a story from the bystanders that it happened like an hour ago or a couple of hours ago, and they called 911, and they're showing these signs and symptoms. This is rapid. This is severe. This is likely to be epidural. Is it possible that he instead cut one of the veins in the epidural or one of the arteries in the subdural? Of course there is, but statistically, chances are it's an artery in the epidural. And then you look for this in the story. Of course, bystanders won't say lucid period, but they'll give you a story like he was hit in the head by a baseball, or he fell off the second story balcony. Anyway, he was knocked out. He lost consciousness, and then he finally woke up like a minute later, and he seemed to be fine. You know, he had a splitting headache, but no wonder, right? He hit his head. But anyway, he seemed to be okay. But then, about half an hour to an hour later, he became unconscious again. So that period of consciousness, of being awake in between the first unconsciousness and the second unconsciousness, that is lucid period. And this is like classic textbook sign of an epidural arterial bleed. What you do is on the way to the hospital, you call notification ahead and tell them lucid period and approximately how long. So the ER, emergency room, knows how serious this is. Oh yeah, bystanders say patient lost consciousness, woke up for a bit, and then lost consciousness again. Subdural, venous bleed, again statistically. Is it possible that the lucid period was from a subdural artery, or this current patient is dealing with a epidural vein. Of course it is, but statistically, and this is what the state test wants you to think about. If it's a slow advance of stroke symptoms, a slow appearance of neurologic and stroke symptoms over days, and the story is that, like, originally several days ago, patient banged his head like on a shelf, or fell off the bed or something, and then everything seemed to be fine otherwise. But then over the next few days, there was a progressing gradual increase of neurologic symptoms, and now the patient has signs of an intracerebral pressure or stroke. Stroke, what is stroke, right? Half of the body is not functioning properly. So because it happened over several days, you think it's venous, and then when you're thinking it's venous, you're thinking subdural hematoma. Here is this graph I added to the slideshow. It's not in your textbook, but it's a nice thing, side-by-side comparison of the two. The blue line is the dura. Okay, so there are three kinds, right? There was an epidural, subdural, and then there's intracerebral. And then the intracerebral is a blood vessel in the middle of the brain burst open. It's just that. Blood vessel inside the brain, burst open. What would cause a blood vessel inside the brain to suddenly burst open? Well, it's probably genetics is involved, but then genetics plus a history of uncontrolled high blood pressure, and or they took a drug that spiked their blood pressure, like they overdosed on stimulants, and suddenly, so they were fine, but then within like an hour or two or less, they're suddenly showing neurologic symptoms. And they also complain of a thunderclap headache. So the headache, that means that the headache appeared suddenly, out of nowhere, like a rumble of thunder. And so everything was fine 1 second, and then a second later, suddenly there's a splitting headache, and it's unbearable, and they can't do anything, and they are calling for help, and that's a burst aneurysm. You may I gave the cardiovascular emergency, and I talked about an aneurysm, but that was an aneurysm in the torso and the abdomen. This time we're going to talk about an aneurysm in the brain. So just like an aneurysm in the aorta, where a section of the artery just bulges out until it finally bursts, that's what's happening, and that's the thunderclap headache. What would cause this? Well, the genetics cause this. It looks like a berry, right? Looks like a little berry sticking out. In fact, it's called a berry aneurysm, and it's called that because on X-ray looks like a little berry is hanging off of a vine. So it's genetics that made this section of wall weaker, but then it's a history of uncontrolled high blood pressure that makes it bulge out. And then one day, the blood pressure spiked even higher than they usually have. Maybe it's an emotional event. Maybe they took some kind of stimulant, took too much of a stimulant. But anyway, it's like a perfect storm. All the factors lined up, and then the aneurysm burst open, and it felt like a thunderclap. What do? Well, you ask. How do you ask if the headache was like a thunderclap? Well, you don't ask the word thunderclap. What do? You ask the Q question. In your own words, tell me what the headache feels like, and listen carefully to what they say and how they say it. So any words they use, to suggest that it was fine, everything was fine 1 second, and then the next second suddenly it was unbearable pain in the head. That's thunderclap. Okay. So how do you know this patient had an aneurysm? Well, the story, the OPQRSTI, the sample, and to put those three together, and now you're worrying this patient may have had maybe having an intercerebral hemorrhage. If somebody's having one of these, should you put on a C collar? Why not? Why not? Because it won't hurt him. C collars won't hurt him. And what if the patient is having a memory issue? Maybe they did hit their head or neck or back, and they just forgot to tell you, or they forgot that it happened. So of course, any neurologic issues, C-spine. All right, what if a penetrating object is stuck in the skull? Same as the penetrating object in any manner last week, you stabilize in place. Get the hashtag roller gauze in play around the head this time. So stabilize impaled object. Get the donut. I have something to say about the donut, but I won't use up your time. So get bulky dressing around the impaled object and stabilize it in place. And then cover the whole thing with dressing to minimize blood loss and to protect the wound. And then finally cover the dressing with bandage to keep the area clean and protected. Of course, injuries to the face and jaw. Okay, so we're done with injuries to the cranium. Now we're talking about injuries to the face bones. So face bones, airway. Face bones, airway. Face bones, airway. GCS. Oh, okay. I guess it's time to talk about GCS. This is GCS. You don't need to wait until somebody is in a coma to calculate their GCS score. Can you see this? In fact, look at the topmost level here. So eyes, verbal, motor, and then as long as their eyes are moving spontaneously, means they're tracking, they're keeping eye contact with you, lights are on, somebody's home, that's a 4. They're talking in complete sentences, their conversation is making sense, that's a 5. And you tell them to do this, to do that, and they do it, that's a 6. 4 plus 5 plus 6 is 15. So somebody who is alert and oriented and doing all of these, you give them a GCS of 15. 15 is the best. If the eyes don't open even to pain, so unresponsive to pain, they're not making any sounds at all, and they are not moving because they don't hear you, but anyway, they're not moving, then that's a 1, a 1, a 1, that's 3. There's no 0 in GCS. The worst possible score is 3, and that's it. This is what you need to know for the state written exam. The best is 15, the worst is 3, that's it. I have never seen an EMT level, BLS level, state written exam where the GCS was somewhere in between. As a paramedic, you have to know the rest. But now, if you are interested in being an A student, and you don't just want to pass, you want to actually know this stuff, how do you remember, how can you remember all of these scores in between? The reality is that nobody really remembers them anymore because, especially because of the electronic PCRs. When you are finished taking care of your patient and now you open up your ThinkPad, your company issued laptop, and you start typing away, you will eventually, inevitably get to the GCS coma screen, and there it is. It's going to be right there on the screen. You just click down, you just click your drop down boxes and you choose the appropriate one, and it automatically calculates it for you there. But if you want to know what you're doing, not just clicking buttons like a monkey, I use the term monkey because of the space, the 1960s space program, because they trained monkeys to go out into space, and the monkeys pressed buttons, and so I think the Soviets did it first, and so they successfully sent a living animal into space and brought him back alive. So we knew it was possible to send humans up there. Anyway, that's what I'm thinking of when I use the monkey analogy. You don't want to be a monkey. You want to know what you're doing. You don't want to just press pretty buttons, pretty colored buttons, because you get a treat. So to know what you're doing, 5, 4, 5, 6. The eyes are 4 choices. You already know that 4 is the best, 1 is the worst. So what are the 2 in between? Well, spontaneous, verbal, pain, unresponsive. So this is the AVPU scale. There, you know eyes. Verbal, you already know that 5 is the best, 1 is the worst. So what are the 3 in between? Well, confused, 5 is they are holding complete sentences and they are talking sense. 4 is they are not oriented to person, place, time, or event, so they are altered mental status. 3, so the 4 is they're making complete sentences, the sentences are not making sense. 3 is they are making words, but the words are not appropriate. They're choosing words that make no sense. 4, they are choosing words that are, I guess, okay, but the combination of the words is not making sense. 3, the words are inappropriate. 2, they can't even make complete words. There's just sounds, random guttural sounds. They have lost the ability to form words. That's 5, 4, 3, 2. Motor, this is the hardest one to remember. 6 is the best, 1 is the worst. There are 4 in between. Don't think of it as 4, think of it as 2 pairs. Let's go down here. Motor, think of it as 2 pairs. The first pair, the better pair, the first pair is the better pair. 5 and 4, localize the pain, withdraw from pain. So what you do is, if they don't obey your commands, then the next thing you do is you pinch them somewhere, like on the shoulder. Pinch them on the shoulder. If they move a hand to where you're pinching them, that's localized to pain. If instead they withdraw their whole body away from the pinch, they are withdrawing away from the pain. Going to the pain is better than running away. And I think of this as like the best analogy I like is you see somebody being bullied in the school playground, and for some reason you don't intervene, so you just sort of let it happen, but you just watch it, and you like the guy, you like the kid, you're rooting for him, you want him to do good, but now some bully is being a jerk. If that kid fights back, curses back, pushes back, punches back, then he's a fighter. So he is a fighter, and so it's like, okay, good, there's a future for this guy. He's going to stand up for himself. He thinks good about himself, so that's good. I mean, it's not great, but it's better than 4. If instead he sort of runs away crying, he's quitting, he gives up, there's something he really, really wants, but the bully is not letting him have it, and he just sort of gives up and says, fine, I don't want it anyway. And then I feel bad for this kid now. He's not gonna fight for himself. He's not gonna go after the things he wants, that goes after the things he needs later in life. Or that's the oversimplified sociology experiment. So that's not so good. It's actually bad. You would rather this person be a fighter, so he turns into the pain. You don't want him to be a quitter. You don't want him to be turning away out from the pain. We already talked about 3 and 2, decorticate, decerebrate. The hands turn in or the hands turn out. So in, out, in, out. That's how you remember it. 6, in, out, 1. That's how you remember motor. And now that's Glasgow Coma Scale. Right. So, wound in the neck. Okay, if it's a shallow wound and not a lot of bleeding, it's like a slow venous bleed, and it's like really slow and it's really small. Okay, just put some gauze on it and tape it over. Done. But what if it's a large venous bleed or an arterial bleed, but especially a large venous bleed? There's a real danger now. Because of the way fluid dynamics works, as the venous blood is heading to the heart, it may suck air in, because remember, veins are not under pressure. So the venous blood, as it's moving its way down to the heart, it may allow air into the vein, but the problem is that when blood touches air, it clots, which means these blood clots are heading towards the heart. So what? Where does blood go after it's finished with the right side of the heart? Can anybody remember? I made you guys draw it as a class twice. So remember, what is the circulatory pathway around the body? Superior vena cava. The veins from the neck join the superior vena cava, and then where does it go? And then where does it go? These clots. And then where does it go? And then where does it go? Think now. Think. Where in the body does it go? These clots. Because wherever these clots end up and get stuck, they're going to cause a problem. I'm going to ask you about this when we meet again. And this time I'm going to remember to ask you. So, a serious wound to the neck is not this. Well, air embolism is the name of the clot, but here it is. Serious wound to the neck, where the large vein, the jugular vein, is impaired. You want to first put the occlusive dressing, plastic occlusive dressing, and then tape it on 4 sides, and then secure it with this bandage. So the dressing is the occlusive dressing, and then you put gauze on top of that, and then you secure it. Now, how do you secure it? Because you could try tape, but the tape won't put pressure, and you need to put pressure. But if you put pressure across the neck, isn't that called a choke? Isn't that called, aren't you strangling the patient? So, neck occlusive dressing. Oh, that's for something else. Yeah, I guess this will do. Yeah. So this, whoever this is putting clear plastic across the wound of the neck. You want to put the occlusive dressing first. Do not put the gauze first. Oh, that's a mannequin. Do not put the gauze first. Put the occlusive dressing first. Why? Because if you put the gauze first, you're kind of making a tent with the gauze under the plastic. Oh wow, these are some nice trauma makeup simulations. I'm going to check these out later. You should too. Do not put gauze under the plastic because you're kind of making a tent of air, and then when you finally put the bandage and put pressure, you're going to squeeze that air into the vein. So put the occlusive dressing first and then gauze on top, and then secure with bandage. Remember the sucking chest wound, you tape on how many sides? 3 sides. With a neck wound, you tape on 4 sides because you don't want air to move in and out at all. And similarly with the abdominal evisceration, do not want the air to move in and out at all either. So tape on 4 sides when you don't want air to move, but with the sucking chest wound you do want air to move, so you tape on 3 sides. And then on transport ABCs, oxygen, right? Okay, injuries to the spine. So it could happen from any kind, from many different causes. And then if the spinal cord is cut, then it is a very serious problem. Axial loading, let's see if they put a picture of that. Well, I guess this is kind of axial loading. The axis, when you think of the word axis, well, I didn't expect company logos. Axial loading. So clearly it's a mechanical term. Trauma. Where is it? Let me see. Oh, here. Very nice. Axial loading. So this poor fellow, this football player, so got hit on the top of the helmet as he was bent over charging into the field, and the helmet pushed down on the head, and the head pushed down on the C-spine, and the C-spine pushed down on the vertebrae. That's axial loading. Axis is this line. I'll draw an axis for you with the line tool. Here's a direction of the axis. Here's a direction of the axis. So the forces is imparted onto, to be more accurate, the axis is like this direction. The force is imparted on the spinal cord, on the vertebrae, and it causes compression fractures. Remember compression fractures? Okay, that's axial loading. Oh, here's compression fracture. So the pressure squeezes on this vertebrae, and have you heard of the phrase, a chain is only as strong as its weakest link? So the vertebrae is only as strong as its weakest segment. And if this is the segment that's extra weak, then it's going to be crushed. That's compression fracture. Rotation or flexion fracture is different, where the body is twisted and that causes a crack. All of these are damages to the spinal cord. Hyperextension is knocking the head all the way back. Now, you may have been told when working with the BVM mannequin to pull that head all the way back, all the way back. Of course, when it's a mannequin, then you want to crank that head all the way back. When you have a real patient, don't do that. Just do the head tilt chin lift only if there's no suspicion of trauma, and you will know you have enough of a head tilt chin lift because you will get chastised when you squeeze the BVM. If there is any suspicion of trauma, never do a head tilt chin lift, just do the jaw thrust. Hyperflexion, meanwhile, is knocking the head all the way forward, and you can see how if it's too much, then it will damage the spine too. Whiplash is when the head is rocked back and forth, so it's not a coup contra coup, but it is damage to the vertebrae, the C-spine. Motor vehicle accidents, falls, all of these can cause injury to the C-spine. A dermatome is not something an ENT will need to assess, but just remember when I said that out of each vertebrae is an exit ramp out of the spinal cord for the peripheral nerves to leave the spinal cord and stretch out into the rest of the body. So these are where all the nerves go. If it came out of C3, it'll head towards the shoulder. If it, which nerves head to the fingers? C6, 7, and 8. Which nerves head to the toes? L5, S1, S2. See how this works? And these are dermatomes. If the patient has some kind of neurological damage, then you take him to the emergency room, and the ER attending calls the neurology consult. If for some reason you're still there at the emergency room, that your supervisor hasn't hurried you out so they can send you on another job, if you're still there in the emergency room, what happens is, and you happen to catch the neurology consult, see your patient, they're going to go up and down the body with tiny little sensory sticks, and they're going to go ask, do you feel that? 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 Going all the way down, checking every dermatome. Paralysis, paresthesia, paresis, tenderness, all of them could be a sign of neurologic impairment. Impaired breathing, hey, yeah, sure, impaired breathing. In fact, this is like the most immediate life threat from a spinal cord injury. That this person, the nerves that are supposed to go to the diaphragm are no longer working, and so the patient's ability to breathe through the diaphragm is impaired, and they could literally go apneic because of spinal injury. Where did these nerves come from? Which part of the spinal cord did these diaphragmatic nerves come out of? And you may think, is it T9? Maybe it's T8? Maybe T7? Trick question. The answer is C3, C4, C5. Wait, C3, C4, 5, that's all the way up here. How can nerves coming out of the neck go all the way down to the diaphragm? What's up with that? It's embryonic development. That's where the first cells of diaphragm came from, around that fetus's neck, and migrated down the torso, and it just sort of pulled the wires along with it. So 3, 4, 5, keep the diaphragm alive. That's a little poem that all healthcare providers know. 3, 4, 5, keep the diaphragm alive. Test question. Priapism, what's that? Look it up. Why do we care? Because there is a muscle that stays closed, stays constricted to prevent blood flow going into this organ. If the spinal cord is cut, that muscle no longer is told to stay closed. It opens, blood flow goes in, and priapism happens. That's why on the focused on the detailed physical exam, you're supposed to check for priapism. What, you think I'm joking? You think I'm fooling? I know there's a current slang term for kids out there that means that I'm fooling, or I'm making a joke, or I'm telling an untruth, but I won't say the slang word because I've also learned that for an old person to say it is just extra cringy. Patient exam overview. Remember this form? Priapism. It's there. Bowel or bladder control. After all, what's keeping those sphincters what's keeping those sphincters, which is circular muscle, closed so you don't have a social accident? The nerves. If the spinal cord is cut, then those nerves no longer work, the muscles open up, and bowel and bladder control is lost. Deformity, of course, so you should palpate up and down the spine if you suspect that there's been spinal injury there. And neurogenic shock. We talked about shock before. Artery and venous muscle constriction is lost, because these smooth muscles that keep the artery and veins constricted is no longer working. Arteries and veins now open up. The same blood in a larger container causes pressure loss. That's neurogenic shock. Control S for save. Okay. Geriatrics, elderly, are more vulnerable to fractures because of osteoporosis, inadequate diet. Senescence is just aging of cells. So, and also loss of osteoporosis, balance problems, so they are also more likely to fall, and something called proprioception, which is a sense of body position. Proprioception. So what proprioception means is, like, remember I said that you don't just have 5 senses, you have many, many more. One of them is proprioception. If you hide your hand behind your back, you don't have to look at it to know exactly where it is, because you can feel where it is. Not because it's touching your back, but hang it in the middle of the air, your hand, and you'll know exactly where it is because you kind of sense it. That's proprioception. As we get older, this sense of proprioception, as well as all the other senses, degrade, and elderly people have a harder time knowing their body, like where it is. So that actually makes falls worse. And absolutely, of course, there's vision and hearing. Makes it harder to know their environment, so also prone to falls. Okay, so how to put a collar on. Your skills instructor has taught you how to put a collar on. You know what, I'll leave it up to them to make sure you're doing it right. Longboard. So hopefully they're taking time, your skills instructors are taking time to teach you how to put a patient on a longboard. Even if we no longer transport on a longboard, we still use a longboard to transfer the patient from the scene to your stretcher. Sometimes, though, a patient should be transported on a longboard if they really do have obvious and significant signs of spinal damage. But that's my opinion. For those of you who go on to the fire department, I heard a couple of fire department instructors saying out loud that the longboard is now contraindicated. I wanted to raise my hand and say that's wrong, but you know what? It was in the middle of a medic class, and I was just a student. I was refreshing, and the other time it was in a continuing medical education lecture, and there was like a big bunch of people there, and I finally decided the argument is subtle, it's nuanced, and nobody in the audience had time. They just wanted to finish it and go home. And then by the end of the class, I also wanted to just go home. And something told me that there was no point in arguing with those instructors. Fire department is telling their students the longboard is now contraindicated in all situations. Who am I to argue with the city of New York? I'm telling you, though, that if the patient really does have very serious, severe signs of spinal injury, loss of post-motor sensory, loss, paralysis in the body, inability to feel, pain, severe pain at the area of injury and above, this person really should be transported on the board. The reason why we're no longer using the board routinely for all suspicion of spinal injury is that it has very serious side effects. And the percentage of people who ended up actually having serious spinal injury was actually kind of small. So New York State decided there was no reason to cause so many people to suffer these serious side effects, which is ulcers, cramping, muscle cramping, claustrophobia, for a small possibility that they have a genuine spinal injury. So instead, nowadays we just use something called spinal motion restriction. Log roll the patient, that's what they are doing here to here, and then they log roll the patient back on. The team leader is always the person at the head. The person calling the count. Everybody moves together on the count of 3. Can you imagine if this guy pulled too soon compared to this guy? They would twist the spine. Can you imagine if they both pulled before the head person was ready and the head got twisted? So they all have to work as a unit and roll on the count of 3, and it's always the head person doing the count. If you're like the guy over here and nothing is happening and you're starting to get impatient, don't call out the count, because it's not your job and you will cause confusion. It's always the head guy. Padding the voids. The voids are spaces between the body and the surface, and in order to reduce pain and cramping and suffering, you should put padding to cushion any spaces. If pregnant, tilt the board to the left. We'll talk about that in the OBGYN lecture. There should always be 3 straps: upper chest, pelvis, and thighs, because that's where the bones are. If you strap across the abdomen, you're going to pinch on the abdominal organs. That's just going to cause all kinds of problems. So, my notes say that when there's obvious spine compromise, immobilize on the longboard. But be aware that there are side effects, so you have to balance out the benefits versus side effects. And the side effects are pain. Iatrogenic means caused by the healthcare provider. Muscle cramps, pressure sores, claustrophobia, even PTSD. Here's me when I was in the EMT class. So when it was my turn to be immobilized, see, chest, pelvis above the knees. I asked somebody to take my picture for posterity's sake. I really wish that we take time to practice longboard immobilization, because like any other skill, if you don't practice it, it increases the chance that you'll do it wrong in real life. So now we do spinal motion restriction. Why is immobilization redlined? Did I spell it wrong? Or is it just not in the dictionary here? Immobilization. Immobilization. Okay. There are alternates to longboard, and if the patient is in a tight space, you can use a scoop stretcher. If the patient is seated, you can use a KED, and they will show those to you in the skills Saturday. So spinal motion restriction is not immobilizing to a longboard. It's using a longboard but transfer them to the stretcher and then remove the longboard. And that in itself is a skill. Removing the longboard from under the patient without compromising their spine is a skill in itself. You really should practice that too. Yeah, here. So anyway, here's a driver being having a. So here, there's the your partner holding manual stabilization of the head, and then another EMT is applying the collar. This is a short board. Well, this is a very fancy short board, because there are simpler versions of the short board where you have to make it yourself with straps. Can you see all the straps here? This is a very time-consuming process. So, if the patient has has a real risk of spinal injury and they're seated, like in a chair or in a car, but they are otherwise stable, then you can take the time to put this on. But if the patient is not stable, then you don't have that kind of time. You have to extricate, and we'll talk about extrication in vehicle operations at the end of the semester. So extrication is also a skill. Anyway. So how to put on one of these? It's the Kendrick extrication device. It says it here, Kendrick. It says it here, Kendrick extrication device. I'm not going to explain the steps, because without hands-on experience, you're not going to remember it. So I'll let the skills instructor show you how to put it on. Here is the discount version. So this is not a KED, it's just an ordinary short board. And then you have 9-foot straps, and there is a way to put these 9-foot straps on. Just be aware that when you practice, you don't want to immobilize the patient to the chair. Know where since you are putting the straps on, then you have to be extra careful to put the straps on properly and don't entangle other things. I'm really sad I didn't get to show these to you in person. Oh, here they are putting the KED behind this lady. Here's a guy getting the KED. For pediatrics, you want to immobilize the baby or the child, because they can have spinal injuries too, and you want to immobilize their whole body. So these are ways to immobilize the whole body. This middle picture is not complete immobilization yet. It's not finished yet. But okay, so let me show you something here. With this crew, the narrow end of the shortboard is up. With the baby, the narrow end of the shortboard is down because you want the wide end so you can tape across to immobilize the baby's head. The green thing is a towel that I curled up into what I like to call the Princess Leia, and it stops the head from moving side to side. Where's the collar? For an infant, there's no such thing as a plastic commercial collar because they don't make them that small. Instead, you're going to have to find a way with bulky dressing to simulate the function of a plastic collar. So there is a separate skill for immobilizing a child, and you get to that too. For somebody who has a helmet on, like a motorcycle helmet or a football helmet, the problem now is that some helmets might block the airway. So here is a gentleman wearing a helmet, and it's getting a way of managing and protecting the airway. In that case, it may need to be taken out. Now, for football helmets, maybe not, because football players also wear like body padding. So between the helmet's cushion and the body padding cushion, the head is actually kept neutral. In which case, you don't want to remove the helmet, you just want to remove the mouthpiece. How do you do that? You ask the football coach, and they carry special keys so that you can unscrew the helmet hinge and then the mouthpiece hinge, and this thing comes off. And just transport them like that. Motorcyclists, unfortunately not, because when motorcyclists, they're wearing a jacket that is kind of thin. It could be leather or denim, very warm, but it's still thin, which means the shoulders are able to drop to the ground. Meanwhile, the cushion of the helmet is hyper flexing the head forward. Now you got to remove the helmet. So there is a separate skill on how to remove the helmet. Again, they'll show you on Saturday. An EMT has to hold manual stabilization of the helmet, and then another EMT slips his hands under the helmet, cups the chin and the back of the neck, and now the first EMT can move his hands to inside under the edge of the helmet and gradually, slowly roll the helmet off the patient. These are the steps of how to remove a helmet. But again, so after they show this to you in skills, then you can return and review this list. And we are at the end of this lecture. So this lecture went fast because I started it late, and I had no interruptions, or I didn't pause to spot test you guys like I usually do. We didn't stop for breaks. So anyway, this is chapter 29, head, neck, face injuries. Good luck on that, and you will absolutely see me next Monday.